Okay. So I have 4 head and neck lecture slots, if I'm not mistaken. My plan was to do a thyroid didactic and then a thyroid unknowns on path presenter, and then a salivary didactic and a salivary unknowns. So for my 4 sessions, that's what it's gonna be. And hopefully that gives us a balance between learning and practicing and all that good stuff. Okay, so for thyroid today, we're gonna kind of start from the beginning because a lot of information on thyroid is gathered before we even see it in surgery path, right? From FNA, from molecular testing before surgery. So I kind of want to go through all of that and give a framework for how to approach it. And it has always stopped me if you have questions. So we'll start with some development of thyroid. We'll talk about how the thyroid nodules are worked up, and then sort of the histologic features of tumors, including genetics and some medical diseases. So for the follicular cells, if you recall, they sort of start out as condensations of endoderm at the base of tongue at the foramen cecum. They migrate down the midline neck in the thyroglossal duct. They then sort of solidify and divide on either sides into the right and left lobes connected by the isthmus. But remember, because of this path of migration, you can get a few developmental remnants kind of in the midline of the neck. So you can get the parietal lobe, which is kind of a remnant of that downward descent. You can also get, of course, thyroglossal duct cyst, which is persistence of that thyroglossal duct, which then becomes cystically dilated. C cells were thought to come from neural crest. However, it's been recently shown that they come from the pharyngeal pouch apparatus, which is referred to as the ultimobranchial body because this is the last pouch to develop. The C cells and the ultimobranchial body cells, which are basically skin, like squamous cells, and we'll see those later, disseminate into the thyroid and kind of land at the upper poles. So anything that's C cell related, like medullary thyroid carcinoma, is going to happen more in the top part of the gland because of that developmental migration. What do they look like? Of course, you know, follicular cells are basically balloons full of colloid. If you cut them in cross section, right, you'll see nice, small, round, dark follicular epithelial cells that are somewhat sort of lobe cuboidal. C cells in the normal thyroid are not usually visible by light microscopy. So if we see them, that usually means they're hyperplastic. They sort of look as these collections of sort of nests, and sometimes they even undermine the follicular epithelium, so you may see colloid. And on high power, they have this granular cytoplasm because they've got these sort of neurosecretory granules in them that produce the calcitonin and very kind of finely stippled chromatin. So C cells versus follicular cells. Because of this developmental migration, right, you can get thyroid ectopia in any place where the thyroid can be. So all the way up at the base of tongue, you can get ectopic thyroid there. If it descends too far down, right, you get thyroid going down into the mediastinum. So we often see sort of substernal goiters. So you can get thyroid anywhere in this entire path. You can get abnormal shapes, bifid, etc. Pyramidal lobes we already talked about. So just things to remember because of this sort of migratory pathway. Thyroglossal duct cyst, which we already mentioned, generally has either respiratory or squamous epithelium, should be in the anterior midline. It is not going to be lateral like a branchial cleft cyst. It is specifically going to be in the midline because that's the only way the thyroid goes up and down. In about 75% of cases, there's thyroid tissue in the wall, in which case sometimes you can get thyroid carcinoma developing in the thyroglossal duct cyst remnant, but that's pretty rare. They do a procedure for resecting these called the cyst trunk procedure. So if you see that, that's what it's specifically for thyroglossal duct cyst, SISTRUNK, in which they take out the cyst, track of the cyst and the sort of middle of the hyoid bone. And so you can submit some representative hyoid bone if you'd like, and sometimes we'll actually see thyroid cyst remnants in the hyoid bone. Other developmental remnants. So we talked about the ultimobranchial body and how it migrates into the thyroid with the C cells. So sometimes ultimobranchial body resides as microscopically visible small nests like this that are sometimes referred to as solid cell nests. Because they derive from that pharyngeal pouch system, they're basically squamous. So they'll stain with P63, P40 high molecular weight keratins, and they sort of have these like elongated groove nuclei that kind of resemble, some people call them resembling like urothelium. But just don't mistake them for papillary thyroid microcarcinoma because of the groove nuclei. You should not see other features like dense cytoplasm or inclusions or whatever. But if you see these sprinkled around and we see them in sign out, those are the solid cell nests. You may or may not see C cells associated with them. You can sometimes get actual lymphoepithelial cysts, meaning sort of squamoid epithelium and lymphoid stroma, which is also probably one of the branchial cleft type remnants that can exist in the thyroid gland itself. Other developmental remnants that you can see in the thyroid gland, we've all seen intra or like very tightly associated parathyroid tissue. You can see thymic tissue in and around the thyroid, right? My criteria for your passing your first month rotation, as many of you know, is can you identify thymus, right? Because we see it all the time. You can see ectopic salivary tissue, even ectopic cartilage in the thyroid gland just because of development. In the isthmus, because of this path of migration, your thyroid sometimes descends through the musculature, and you can actually get this intermingling of skeletal muscles and thyroid tissue specifically in the isthmus. This does not apply to the bilateral lobes. And so in the isthmus, we're very kind of conscientious about what is really the thyroid space and what is not, right? So this is not thyroid carcinoma invading muscle. This is just normal. But we'll see. We'll talk about that more later. Some other fun facts about thyroid, normal thyroid, include these things that you can see in the lumen of the follicles. And probably some of the seniors know what this is. Anybody? All right, these sort of pointy refractile things are some kind of crystal, okay? They are only present in colloid of thyroid follicles. They're calcium oxalate crystals. Why do I care? Because sometimes, especially on a frozen or you're not sure what's going on, you can have something like this on the bottom left. That on the bottom left is not thyroid, that's cystically dilated parathyroid. And so sometimes when one is trying to distinguish thyroid versus parathyroid, it can be challenging, especially if the parathyroid has this pseudofollicular dilation. So if you see calcium oxalate, that 100% means you're in the thyroid, not in the parathyroid. Other features are characteristics of the nuclei. Usually parathyroid is much more small and round and dark and sort of evenly spaced, almost like a fried egg-like appearance to the cells. Thyroid is a little bit more variable. But calcium oxalate, if you see it, can be helpful for identification of thyroid tissue. Okay, the next thing that we sometimes see in thyroid, what are these cells in the middle? What? Macrophages, histiocytes, right? So there's a multinucleated giant cell. There are all these foamy histiocytes, and they're sort of like busting out of this follicle, right? You can see the follicular epithelial lining on all sides, but then on this side, it's sort of, there is no follicle lining. So sometimes this might be referred to as palpation thyroiditis, meaning there's some kind of micro rupture in the follicular epithelium such that colloid leaks out and the histiocytes come in and sort of try to gobble it up. It has been thought that this is potentially due to vigorous manual palpation. Whether or not this is actually true or not, I don't know, but it got this term of palpation thyroiditis. So we often see these histiocytes swarming the follicles. That's also totally fine and nothing to worry about. Okay, so questions or comments on sort of variations of normal. Okay, so now we're gonna move into working up of thyroid nodules, because that, for the most part, that's what we see, right? We sometimes see thyroidectomies for refractory medical disease like Graves or Hashimoto's. We actually just had a cool one the other day of a patient who had a post-COVID subacute thyroiditis episode, and so her thyroid had these like interesting like subacute thyroiditis findings. But anyway, that's rare, right? Mostly we see nodules. Patients are getting their thyroid out because there's a nodule that they have to diagnose or they have to treat because it's cancer. Over half of the general population is thought to have thyroid nodules. Mostly they are benign, right? So if you take any given human being with a thyroid nodule, just statistically, chances are it's benign. But in the days of medical imaging and people are getting CT scans and ultrasounds and whatever, for all these reasons, we're picking up a lot of thyroid nodules because people are having imaging for other reasons. So our prevalence of thyroid nodules identification is very high, probably not only because you can see it yourself, your doctor can manually palpate it on exam, or you can identify it on some kind of other medical imaging. So of course, the first step, so those of you who've done cyto, right, understand that thyroid FNAs are really, really common, and mostly they are not done under manual palpation guidance because you're in a tricky spot, right? You've got the carotid artery, you've got trachea, you've got all these things going on in the neck. And thyroids can sometimes have multiple nodules, right? So one needs to know that we are targeting the nodule of interest. Hence, they are often done under ultrasound guidance with cytology there for rapid on-site evaluation to determine if there is adequate sample or not. So that is kind of standard of care in this institution. Core biopsy is not really recommended. It's a very vascular and traumatizing area, so core biopsy can cause a lot of tissue damage, and there are not great sort of standards of criteria for diagnosis of core biopsy like there are for FNA, and sometimes the nuclear features on core biopsy can be somewhat distorted, so it can be hard to tell cancer or not cancer. So FNA. When is something ultrasonographically suspicious enough that it should undergo an FNA? And the American Thyroid Association has this whole risk stratification system for ultrasound, ranging from it's sort of macrocystic, it's hypoechoic, it has a regular border, right, all the way to it has stippled sort of microcalcifications, which could mean Samoma bodies, or irregular borders, or irregular size, undulating borders. So depending on what they see on ultrasound, that will then direct the need for a fine needle aspiration biopsy. So we know there's a TIRAD system, low to high meaning very suspicious, low meaning less suspicious. And so then ultrasound helps determine the need for FNA. FNA helps determine the need for surgery. And we're gonna go through all of the FNA categories. Don't worry. And of course, once we get to surgery, histologic features will determine the final diagnosis, right? Because cytology is mostly just a screening test to tell you, are you certainly benign? Are you certainly malignant? Or are you somewhere in between and you need surgery to tell? So, if most FNAs can be sorted out and should be sorted out into benign, in which the patient can be observed, or if it's symptomatic, they may still undergo resection of a benign nodule just for symptomatic purposes. Or if it's malignant, right, it's basically gotta come out. If it's malignant, it still might not buy the patient a total thyroidectomy, but it will certainly buy the patient a lobectomy to get the cancer out. So in the Bethesda system for FNA, Bethesda, because that's the city in Maryland, right, where these criteria were determined many, many years ago, and now this name persists and it has updates and updates and updates. So in the current Bethesda system suggests your expected rates of malignancy from what these cytologic diagnoses are. Retrospectively at the U of C, our rates of malignancy fall nicely kind of within what's expected for Bethesda. So basically we're doing okay with our diagnoses. We kind of care about the 3s, the 4s, and sometimes the 5s, meaning indeterminate. Like the cytopathology team cannot definitively tell whether this is benign or malignant, and we'll show you examples of why and what this means for preoperative molecular testing. And so anyone with a Bethesda 3, 4, and sometimes 5 can opt to do molecular testing on FNA to determine if this cytologically indeterminate group can be pushed down into a cytologically benign or pushed up into a more worrisome for cancer group. And so that's currently standard of practice for thyroid aspirations, is to send for molecular testing anything in that indeterminate category, because you want to be able to spare surgery for those that don't need it because it's actually benign. And triage people for surgery in which that actually might be malignant. So there are 3 commercial tests for thyroid cytology. One of which is Veracyte's Afirma, which is probably the more common test in the country because it was the first one, but I would argue it's maybe not the best. We here can send to both Interpace and Thyroseq. Interpace is called ThyGenNext and Thyromere, and we'll talk about what that means. And then Thyroseq is the newest one out of Pittsburgh. They're also pretty good. So all 3 of them have similar concepts. They will report out a gene expression profile, whether that be from messenger RNA or microRNA patterns that basically sort the nodules into patterns that are more commonly seen in benign and more commonly seen in malignant. These are proprietary, these are not specific gene mutations or fusions, these are messenger and microRNA profiles that either sort with benign or sort with malignant. So these red things. Then they also do a second arm of the test, which is specific single gene mutations or gene fusions that are present in thyroid neoplasms, as you can see here in green. Some are specific to malignancy, and some are just specific to neoplasia, and we'll get into that in a second. But realize that there are these 2 arms. If you are negative in both of those arms, this is really, really helpful to rule out malignancy and to avoid surgery. So they cite, anywhere between 2, 4, 5% risk of malignancy in a completely negative, which is basically similar to what you'd expect on a benign FNA, very low single-digit numbers. If you have a positive or a suspicious result in any of these categories, your risk of malignancy is highly, highly variable and is dependent on what is actually found. So what can actually be found, and how do we frame this in our minds before we even look at the thyroidectomy, right? We can anticipate what we might be seeing based on what those mutational results are. So we know that follicular pattern neoplasms, like follicular adenoma and follicular carcinoma, both have the same driver mutations, and there is genetic overlap right between benign and malignant. So this group of mutations does not tell you whether you're cancer, it tells you whether you are a neoplasm. That's most commonly RAS, That's a specific variant of BRAF called K601E. That's Paxate PPAR gamma fusion, and that's one of these new THATA IGF fusion genes. Mutations and fusions that are specific to papillary carcinoma include BRAF V600E, which, as you all know, we have the immunostain for, RET PTC fusions, NTRK fusions, and other BRAF fusions are cancer specific. High risk mutations, including TP53 and TERT promoter, are usually more commonly found in higher grade cancers like poorly diff or undiff or anaplastic carcinomas, but not like 99%. 1% of these is thought to be found in benign neoplasms, but if you see one of these, it should make you more suspicious for something high grade or malignant. And then lastly, if you're dealing with something of C cells, which would be medullary, you're going to be dealing with RET mutation, not RET fusion, but RET mutation, okay? So depending on what you see, you know whether you're dealing with a follicular neoplasm or a cancer. But some cancers don't have genetic drivers, and so we can't sort of know what's going on based on the molecular, but the vast majority of drivers of thyroid neoplasms are now increasingly being understood. So back to that molecular testing, if you have a negative mutation profile and a negative gene expression profile, again, you're basically likely to be benign and you do not need surgery. If you have a presence of a mutation that is a follicular neoplasm type mutation, like we already talked about, RAS, Paxate, PPAR, whatever, this can be a follicular adenoma, this can be follicular carcinoma, or this can be what we're going to talk about as NIFT-P. If you have a mutation that is a cancer-defining mutation, that's completely different, right? And you know you have cancer, not just a neoplasm. What if you have negative mutation, no driver mutations, but still a positive gene expression profile? It's basically saying we don't know what the driver is here, but there's still a risk that this can be cancer, so it still needs to come out. I don't care what the reported risk of malignancy that the commercial companies say. They can say 20, 30, 40, 50, 60, or 90. I don't care. What I care is what's the mutation. Because if it's a cancer-defining mutation, there is 100% they have cancer. If it's a follicular neoplasm-defining mutation, very low chance that they have cancer, and I don't care what the percentage they say is, okay? So that's why I don't care that you are looking at the percentages. I care that you are looking at the gene expression profile, positive or negative, and the mutation, what kind is it? Does that make sense? And so that informs our diagnosis on histology, because I know that if something has a BRAF V600E mutation, it's going to be PTC, right? Or if something has a RAS mutation, I have to decide whether it's going to be cancer or not. Yes? Yes. Okay. So we're going to correlate all of these things, all of these cytologies with surgicals. So, okay, we're going to start at the beginning. Sheets of bland follicular epithelial cells, lots of colloid. You're probably dealing with something that's benign, like a macrofollicular adenomatous nodule. The reason I have started using macro or microfollicular, right, to describe the size of the follicles is because this correlates specifically with what they see on FNA, right? So if on FNA they see basically large walls of a large follicle and tons of colloid, that to me implies that these are large follicles, not small ones, right? So hence macrofollicular. So we try to correlate with what we see and what they see. The current term for multiple of these in one thyroid is follicular nodular disease. No longer are these referred to as colloid nodules or hyperplastic nodules. This is kind of antiquated terminology because we don't really know whether they are hyperplastic or neoplastic. We say adenomatous or adenomatoid because we really cannot know whether they are neoplastic unless they have a known driver mutation or they have clonal X inactivation. And this cannot be seen with your eyes, right? You can't see a RAS mutation with your eyes. You can only see whether it's benign or malignant, and so hence adenomatous rather than adenoma or hyperplasia. Okay. Other benign diagnoses include those that are full of lymphocytes in the background and clusters of oncocytes, which is generally specific to some kind of lymphocytic thyroiditis. Sometimes in Hashimoto's or chronic lymphocytic thyroiditis, you can get sort of this nodularity, and sometimes they present with dominant nodules in the background of nodular hyperplasia from Hashimoto's. And so you might sometimes get an FNA just of Hashimoto's. And it recapitulates the significant chronic inflammation in the background with oncocytic change of your thyroid follicles. This is essentially pathognomonic of Hashimoto's thyroiditis. Chronic lymphocytic thyroiditis with germinal centers and oncocytic change of follicles. We know oncocytes as being a histologic manifestation of enlargement with granular pink cytoplasm because of the mitochondria, and enlarged nuclei with prominent nucleoli because these are metabolically active cells. Perthal was the word for oncocytes in the thyroid gland, but because we're getting away from eponyms in pathology, and Perthal probably didn't even describe oncocytes, he probably actually originally described C cells. So we're not calling these Perthal cell nodules anymore, but you will see this in the literature and in history. So Perthal specifically refers to oncocytes of the thyroid, but we call it oncocytic. So in terms of all the various sort of medical thyroid diseases, rather than go through all of them individually, I put them in a chart for you. So we anywhere from chronic lymphocytic or Hashimoto thyroiditis related to anti-thyroid peroxidase antibodies, right? So these antibodies basically are anti-thyroid, and they sort of destroy the thyroid follicles, and you end up with a hypothyroid state, right? Hashimoto's, you generally end up with a hypothyroid state. Graves' disease, you generally end up with a hyperthyroid state because you have what is called TSIs, or thyroid stimulating immunoglobulins. So rather than destroy the thyroid, they activate the thyroid, and you get this hyperplastic change that needs to be treated medically. Other thyroidities include the fibrosing or the Rydell thyroiditis, which is thought to be an IgG4 related disease with lots of plasma cells. You can get sort of the granulomatous or subacute post upper respiratory viral thyroiditis that can range anywhere from granulomas to just diffuse fibrosis. And then there are these rare genetic diseases called dyshormonogenic goiters, in which you have genetic defects in thyroid hormone function or thyroid hormone production. So you get this sort of bizarre kind of microfollicular, very hyperplastic looking pattern throughout your thyroid that can be confused for Graves' disease. But these are, aside from the left two, right, which we see commonly, these are pretty rare, but you may see them. Okay, questions? All right, moving back into our FNAs, in terms of, so we've seen benign, we've seen Hashimoto's. What about something that doesn't have many cells, but the cells are atypical, right? So they start to have wrinkled membranes and grooves, maybe some very subtle chromatin abnormalities, but not enough of these to 100% say this is cancer, but enough to make me worry that there's a PTC in the background. So this is called AUS, atypia of undetermined significance, with nuclear atypia, meaning this could be PTC. This is different from architectural atypia on cytology, also meaning there are few cells, but instead of having these large sheets of follicles, I have these little tiny, weeny little microfollicles like little rosettes. That means this is a very cellular, a possibly very cellular neoplasm because it's rich in cells and poor in colloid. This implies that this might be a follicular adenoma, right, or a follicular carcinoma. But this is referred to as AUS architectural, right? So atypia can be nuclear and atypia can be architectural based on whether it's the size of the follicles or the shapes of the nuclei. Or it could be certainly be both, right? But these are the patterns of AUS that we have. Keep going, right? And you might now have a smear that's very, very cellular with lots and lots and lots of microfollicles. But in general, the nuclei are bland. So now this is the suspicious for follicular neoplasm category, meaning, again, it could be very cellular, it's very colloid poor, it could be a follicular adenoma or a follicular carcinoma, but I can't tell. So generally, if you have only microfollicular architecture, generally you're going to end up being a follicular adenoma. If you have nuclear atypia, your risk of being an actual papillary carcinoma is higher. And if you have that highly cellular solid kind of pattern, then you can end up being either papillary or follicular. And so we'll see what those look like. This is the corresponding histology, right, of those microfollicles on FNA, meaning really, really small and compact with little colloid, but on low power, right, very, very cellular in contrast to normal, sometimes with a capsule, right? So basically, we will call this a microfollicular adenomatous nodule, or essentially a follicular adenoma, depending. Grossly, usually these are sort of more solid and fleshy compared to the background, but they should be well circumscribed without any invasion into the adjacent tissue. They don't have to have a capsule, but they can. At the end of this lecture, we'll talk a little bit more about grossing, but so hold on for that. What happens if you have a follicular adenoma that has a invasion? Of course, then it's follicular carcinoma. So the amount of times you're going to see the classic capsular mushroom-shaped invasion that they talk about in the textbooks is probably very rare, and usually you may find satellite nodules out here without the nice stalk, but you know, that's related to the plane of sectioning, right? And so if you catch the stalk, great. If you don't catch the stalk, you still have to be mindful that these things outside the capsule could be follicular carcinoma, foci outside the capsule. Certainly, angioinvasion or vascular invasion, 100% is cancer. And when you guys are looking for angioinvasion, you're not looking for one cell or two cells or like a cluster. You're looking for a big muscular vessel, which is generally a vein, in which there's a tumor plug that is completely surrounded by endothelium, often with some sort of fibrous adherence to the wall or fibrin thrombi that tell me that there's been breach into the vessel with endothelial injury and activation of the clotting system. And so when you have true angioinvasion, this means that these things can travel to visceral sites like bone, lung, liver, brain, right? As opposed to lymphatic invasion, which is generally small, and generally these things are going to lymph nodes, okay? So angioinvasion is highly clinically significant, but we don't want to over-interpret angioinvasion in tiny little, like, lymphatic vessels, for example. Okay, so that's diagnosis of follicular carcinoma. Back to FNA, what if your cells show oncocytic features rather than the bland follicular epithelial features? So those being, again, this granular cytoplasm, large nuclei with prominent nucleoli. You could be dealing with an oncocytic follicular neoplasm, formerly known as Hürthle cell, right? So just like you can get follicular adenomas and follicular carcinomas, you can get oncocytic adenomas and oncocytic carcinomas. Basically defined by a predominance of oncocytic cell morphology in the tumor. These are now separate from follicular adenomas and follicular carcinomas because they've been shown to be genetically diverse. They have fewer rates of the known drivers like RAS, PAX8, PPAR gamma, and higher rates of things like mitochondrial DNA mutations and sort of copy number alterations, especially of chromosomes 5 and 7. So it's thought that these are genetically in their own sort of pool, and therefore they're pulled out from the follicular adenomas and follicular carcinomas. But the criteria for malignancy is the same. Angioinvasion, capsular invasion. You can see here now nice mushrooming through the capsule. And you can see that in some foci, right, there's not a stalk, but it's the exact same morphology right outside the capsule. Okay. So in both follicular and oncocytic carcinomas, we are concerned with identifying angioinvasion, because this is the most top predictor of behavior, which is going to be distant metastasis. Lymph node metastases in these tumors are very uncommon. They do not tend to enter lymphatic vessels, unlike papillary, which tends to enter lymphatic vessels. We also want to note if there's any extra thyroidal invasion right into the surrounding adipose tissue or skeletal muscle of the neck. And we want to see if there are any high-grade features like increased mitosis or necrosis, because that could push you up into a high-grade category. And we'll talk about high-grade cancers shortly. Okay. All right, moving on into our FNA categories of highly cellular, but also with nuclear atypia, nuclear enlargement, and our favorite diagnostic feature of papillary pseudo-inclusions, right? So then we have PTC, and you all know PTC very well in its classic form with papillae, with nuclei surrounding the papillae that have these atypical features, right, which are enlarged, overlapping, grooved, wrinkled, chromatin clearing, pseudo-inclusions, all the things, right? And psammoma bodies, which are these concentrically lamellated calcifications that are small and often show up on ultrasound as those microcalcs. Very commonly, as we said, are already in the lymph nodes. So lymphatic invasion is very common. Stromal sclerosis is very common. You can sometimes even get stromal ossification, right? So if you ever, sorry, I don't have a picture of it right here, but if you have a nodule that is ossified, bone, always try to find cells that could be diagnostic with PTC, because it is not uncommon for PTC to also ossify. Let's talk for a minute about the nuclei. So what happens in PTC nuclei? It's thought that the nuclear membrane surface area sort of increases, and the nucleus doesn't really know what to do with itself, so it kind of folds in on itself. It can fold into this groove, right? If the groove is very deep, it can look like this indentation or cup shape, so right, sort of depending on if you're looking at it flat or if you're looking at it face on. If you cut or look at a deep indentation face on, what you're going to see is a pseudo-inclusion, right? So this is basically an intussusception of the cytoplasm into the nucleus. So you see cytoplasmic material in the center. That's different from chromatin clearing, which was called Orphan Annie eyes in the past because of the Orphan Annie cartoon, in which case they have no pupils or irises or anything, right? They just have white space, dead space in the middle with dark chromatin marginating to the periphery and nothing in the center. No cytoplasm, no chromatin, no nothing. So this is chromatin clearing, and these are all manifestations of that redundancy of the nuclear membrane. Okay? Okay. So you can have artifacts that resemble pseudo-inclusions that sometimes are referred to as pseudo-inclusions, right? So we're getting very like meta here. True pseudo-inclusions, you should be able to walk from the cytoplasm to cytoplasm again, right? So you've got a cell membrane, cytoplasm, nuclear membrane, chromatin, nuclear membrane, cytoplasm. Okay, you need to see those features in order to call something a pseudo-inclusion. You can have these fuzzy or blurry or bluish or whitish things in the nuclei that are artifacts that are not real and shouldn't. Please, we're going to work on identifying true pseudo-inclusions in our sign-outs. These are not. These are fake. These are artifacts of processing or artifacts of biology, and they do not count as true pseudo-inclusions in PTs. Okay. There are various subtypes of papillary thyroid carcinoma, some of which are worth mentioning. The two on the left, the tall cell and the columnar cell, are probably the most confusing because you're like, well, I don't understand why is tall not columnar and columnar not tall? That implies that both of them have heightened structures. Yes. However, they're different. So tall cell subtype generally on low power looks very pink because it has these elongated cells, very, very densely eosinophilic cytoplasm, often in these very long, straight tracks with robustly atypical PTC-like nuclei and are generally 100% BRAF V600E positive. It is thought that they may be somewhat worse prognosis than regular PTC. Columnar cell, completely different. On low power, looks very blue. Looks like you're almost looking at endometrial carcinoma. It's so blue. That is because it doesn't have that pink cytoplasm. It actually has these very elongated blue nuclei, sometimes with sub or supranuclear cytoplasmic vacuoles. These are a heterogeneous group of tumors, many of which do not actually have PTC-like genetics. So keep your eye out for what's going to happen to columnar cell carcinomas, because I think they might not actually be true PTCs, but currently they're classified under PTCs, and generally can be aggressive, but only if they show invasion, not if they're circumscribed. Okay. Diffuse sclerosing subtype of thyroid carcinoma is generally found in young females, in which case the tumor burden in the neck is humongous. So they have big primary tumors, they have bilateral involvement, they have tons and tons and tons of lymph nodes involved, just tons. And you're like, I don't know how this person can breathe with all of this shit in their neck. And so that should be trigger one. Trigger two is they have these squamous morioles. They have numerous psammoma bodies in bilateral lobes. And they often have kind of a chronic lymphocytic thyroiditis pattern in the background with fibrosis and inflammation. So diffuse, because it generally involves both lobes. Sclerosing, because it has this fibro-inflammatory background. And then morphologically, morioles and psammoma bodies. The other tumor that is known to have squamous morioles is cribriform morular, but the background here looks different. It has this Swiss cheese kind of cribriform pattern. And if you see this type of pattern, throw on a beta-catenin. And if you have beta-catenin localizing in the nucleus, you may raise the subtype of cribriform morular. This can be associated with FAP, so the patient should be germline screened if they do have beta-catenin in these tumors. This is removed now as a subtype of papillary thyroid carcinoma. It's just cribriform morular thyroid carcinoma because it is not entirely certain if this is of true follicular cell differentiation because it's PAX8 negative. And we know that thyroid markers are what? TTF1, PAX8, thyroglobulin. Those are our markers of thyroid differentiation. You don't have PAX8. They do have TTF1. So people are uncertain what this actually means if these are of conventional follicular cell differentiation. So if you just remember that they are now pulled out, they're not a subtype of PTC anymore. All right. Generally, for prognosis in PTC, we're talking about, is there extrathyroidal extension into strat muscles? Are there many and large lymph node metastases? Are there high-grade features like mitoses and necrosis? Or are there morphologic variants of aggressive behavior, including tall cell, or the very, very rare hobnail cell type, which we rarely see. But conceptually, that's what we're thinking about in PTC. What about other tumors that may have funny looking or sometimes referred to as PTC-like nuclei? There are basically two of them. One of them is hyalinizing trabecular tumor, which essentially is a benign behavior, but it has wild PTC-like nuclei. What it presents as is almost on low power. It looks like a follicular adenoma. It's really, really circumscribed and doesn't have papillae or follicles. it just has these trabecular cords, so hence trabecular, right, these elongated trabeculae. And within the trabecular cords, the nuclei are wild. They're enlarged, they're grooved, they're wrinkled, they've got pseudo-inclusions. For all intents and purposes, this looks like a PTC nuclei, but zoom out, it's not. So this is HTT, and this has recently discovered PAX8 GLIS1 or GLIS3 gene fusions that are unique to this morphology. Okay, the other thing that has PTC-like nuclei is so-called NIFT-P, non-invasive follicular thyroid neoplasm with papillary-like nuclear features. This is a follicular neoplasm, right, that is circumscribed, composed of follicles, and for all intents and purposes is a quote-unquote RAS-like, right, one of the follicular neoplasm tumors that behaviorally is benign, biologically like a follicular adenoma. The only thing that makes it different from a follicular adenoma is that it has these funny looking nuclear features. And so I want to talk you a little bit through the history of NIFT-P, because I think when you go out and practice, people's opinions are going to be all over the place. But if I can make you believe in my opinion, then maybe we're getting somewhere. So NIFT-P was born in 2016 out of the tumor formerly known as non-invasive follicular variant of papillary carcinoma, okay? So this was written up in the New York Times because it was such a huge shift. Doctors reclassify a thyroid tumor, it's no longer cancer. And so when you look at this on low power, you're like, that is a freaking follicular adenoma, right? Like that is a microfollicular adenomatous nodule. In what world is this PTC? It was PTC because it had PTC nuclei. So in all of our brilliance as pathologists, we de-emphasized the overall architecture in favor of an overemphasis on the nuclear features. But now, retrospectively, in our increased knowledge, we now no longer call these non-invasive encapsulated follicular variants of PTC. We now call them NIFT-Ps if they meet certain criteria, which I'll go through in a minute, because they never metastasized, right? So when we didn't know any better, we overemphasized the nuclear features and underemphasized the architecture. Now we realize actually, if these don't have invasion, they don't metastasize. So basically they're biologically like follicular adenomas, they just happen to have some funny looking nuclei. So we know that the non-invasive encapsulated follicular variants of PTC are basically RAS driven, unlike the classic variants of PTC, which are BRAF driven. And so they got split, right? So NIFT-P came out and sorted with the follicular neoplasm group. If you have something that is a NIFT-P, but it has capsular or vascular invasion, the terminology in the WHO, unfortunately, is still to call these invasive encapsulated follicular variants of PTC simply because of the nuclear features being present, when we know that they are biologically RAS-like and they will have hematogenous metastases in the presence of angioinvasion, exactly like the follicular adenoma, follicular carcinoma paradigm. They just happen to have some funny wonky looking nuclei. So there's kind of a biological understanding, right, that NIFT-P is follicular adenoma with nuclear atypia, and invasive encapsulated follicular variant of papillary is basically follicular carcinoma with nuclear atypia, which is why, to me, the BRAF versus RAS line is so important, because biologically these are completely different animals. Lymph node metastases, good prognosis, right? Vascular invasion, hematogenous metastases, they can spread all over your body, right? So very, 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 very different. Which is why knowing the genetics on the FNA can really help you predict the biologic behavior of some of these things. In the past, right, follicular variants of papillary may have prompted completion thyroidectomy, radioactive iodine therapy. Now with the diagnosis of NIFT-P, you're done. You get observed. So we've spared patients a lot of additional trauma by not giving them a cancer diagnosis, right? And they don't have to have the other negative ramifications, negative side effects of thyroidectomy. Because radioactive iodine and hormone replacement with Synthroid is not a picnic, right? It's not a walk in the park. And these patients have psychological ramifications and physical ramifications, and the economic ramifications to a cancer diagnosis. So we've done good. We're going in the right direction. Basically, if you care about the original NIFT-P papers, the 2016 and the 2018 revision, basically, you have to make sure that there's no invasion. Fine, just like a follicular adenoma. You have to make sure that there is either zero or no, or low percentage of papillae, which is still controversial. No pneumoma bodies, no high-risk features like necrosis or mitosis, certainly no invasion. And so the subtlety, right, between are you going to diagnose something as a follicular adenoma or as a NIFT-P, the subtlety lies in how you as a pathologist perceive the severity of the nuclei. So I can talk for hours about this because I think it's really interesting, so you got to stop me. But we recently published a paper in the Endocrine Society of people all over the world who gave their opinions on NIFT-P versus follicular adenomas. And all of us from, Japan to US to Mexico, whatever, reviewed all these tumors. And we're like, do you think this is adenoma or NIFT-P or PTC? And not surprisingly, the Americans self-reported and actually diagnosed more aggressively, right? So we would call something a NIFT-P that somebody in Japan would be like, that's fucking follicular, that's a follicular adenoma. Like, what are you doing? Or we would diagnose something as variant of PTC that somebody in Japan would be like, maybe that's a NIFT-P, okay? So depending on who you are, what your philosophy is, who you trained with, what country you live in, you could get a cancer diagnosis or benign diagnosis or something in between. And I think this is where we need, I'm getting hot just talking about it. This is where we as a pathology community can make a difference, right? In terms of patients' lives. And I feel very strongly about not overdiagnosing cancer when we don't need to. And that's why I believe that the genetics and the overall architecture are more important than whatever little wrinkly weird nuclei that you might see, right? So if you have robustly horrifying nuclei, maybe be more worried and find out what the genetics are. If you have maybe a little bit of wrinkly nuclei here and there, but then over on the other side of the tumor, it looks completely fine, maybe back off, right? Because we don't want to overdiagnose cancer. But we do want to make sure that it's not invasive, of course. We do want to make sure that it doesn't have a cancer-defining mutation like BRAF V600E or a high-risk mutation, things like TERT promoter, right? So we will practice these criteria. The other high-level thing for those of you who have heard me rant about this is this 30% insular solid trabecular growth. So once you get advanced in your thyroid practice and you're looking at something, it's circumscribed, it looks like a NIFT-P, and yet you now start to have trabecular growth that's more than 30%. Does that now mean you have to call it a PTC? In my opinion, no, because there's still no invasion. And this number has not been validated scientifically. That it's random. They could have picked 20, they could have picked 50, it's completely random. So now there are papers coming out saying, oh, the solid non-invasive PTC with trabecular growth, guess what? Has RAS mutation, and guess what? Also doesn't metastasize. So this is going to go away. I'm 100% certain that's going to go away. Okay, that was my high level NIFT-P talk. I'm sorry, but you will go out into practice and you will get questions on this. And so I'm trying to preempt some of that thought pattern by making us question, where do these criteria actually come from, and are they valid? And my answer is sometimes they are not valid because they came from thin air. Okay, questions? All right, NIFT-P over. Next, what happens if you have something on your biopsy that's wacky, weirdly pleomorphic, maybe there's some grungy necrosis or mitotic activity, Now we're dealing with, oh my gosh, could this be a high-grade malignancy? So now we're moving into the aggressive thyroid cancers that are the high-grade non-anaplastic, which are the poorly diff and the high-grade diff, or the anaplastic. Basically, anaplastic doesn't look like thyroid anymore. You look at it, you're like, I don't know. Looks like sarcoma, looks like squamous cell carcinoma, versus the high-grade still looks like thyroid, but it has necrosis and mitoses. There's development from pre-existing papillary or follicular, usually. High-grade differentiated is sort of years to decades of survival. Anaplastic is months, right? So if a patient has anaplastic thyroid, their best chance is if they have a BRAF mutation and they can go on a BRAF inhibitor. Otherwise, they'll die. These things suffocate them in their neck and they die. How do we make a difference in the non-anaplastic group between these two categories of poorly differentiated and high-grade differentiated? This is a new concept in the WHO. If you go away with anything, the one thing I want you to remember is that what makes a high-grade carcinoma is the presence of increased mitoses, some say between 3 and or 5 per 10 high-power fields, basically, or necrosis. Either of those two criteria will push you into the poorly diff or the high-grade diff. The other features being solid growth, absence of papillary nuclei, any growth pattern, any nuclei. Bottom line is mitoses and necrosis. The conventional poorly differentiated carcinomas are generally those that are RAS-driven, and the conventional high-grade differentiated are generally those that arise from a PTC. So on low power, when you see something super blue that has like 0 colloid and is very solid and has mitoses and necrosis, that is the conventional poorly differentiated thyroid carcinoma. So in thyroid, but unlike in other organs, there's a well diff, a moderately diff, a poorly diff. When you say poorly diff in thyroid, that's not just describing a morphology. That is referring to a highly specific set of criteria and an implied prognosis. So when you call something poorly diff in thyroid, you mean that it has solid growth. You mean that it has increased mitoses and necrosis. And you mean that it generally is going to behave way worse than a papillary or follicular. The counterpart of that on a PTC background is this so-called high-grade PTC, right? Where you can have solid growth, you have mitoses and necrosis, but you still maintain the quote-unquote papillary-like nuclei. Still, this behaves worse than conventional PTCs or FTCs. So the subtleties notwithstanding, mitoses, necrosis. Follicular carcinoma can also be high grade without being poorly diff, meaning you still have follicles, you don't have solid growth, but you have mitoses and necrosis. So now this is a high grade PTC, because conceptually, the only thing that differentiates a high grade follicular carcinoma from a poorly differentiated carcinoma is solid growth or not solid growth. This is just historical minutia from how we got here today. But where we are today is mitoses necrosis, okay? All the rest we can figure out historically based on tracing the literature. But we don't have time for that. I'm already over. Okay? Questions? Okay. I'll spend a couple words on medullary. Generally, this is diagnosable on FNA. On morphology, it's very solid with this stromal material in the background, which of course is amyloid. What is it? It's calcitonin. It's the calcitonin protein that gets conglomerated in tissue and creates these amyloid pools. But otherwise, these look like C cells with granular chromatin, very granular cytoplasm. You can throw your calcitonin stain on it. It's going to be positive. The patient's going to be high serum calcitonin, hypocalcemia, all the things. Generally, in medullaries, we now assess for RET mutation, because if there's RET mutation in the tumor, there could very well be RET mutation in the germline. And all patients now generally get some kind of screening because we realized that more medullaries end up being familial than we originally thought. So they're kind of being worked up for germline anyway. If it's unifocal, if it's older, more likely to be sporadic. Of course, if it's multifocal, younger, more likely to be familial. These can go both to nodes and distant sites. Okay, 902, you tell me what you want me to do. Can you stay for a few minutes? Okay, so just to recap, if you care about understanding these genetics, check out this paper. This is the 2014 TCGA study that basically sorted all follicular pattern thyroid neoplasms into those that are BRAF-like, that resemble classic PTC, and RAS-like, that are more follicular neoplasm-like. So when I am telling you RAS-like versus the BRAF-like, this is where that came from. And basically, you can tell based on what mutation or fusion you have, which side of that line you are on. And so BRAF V600E, BRAF fusions, RET fusions, those are essentially all on the left side of the line. They are BRAF V600E-like, they are PTC-like, true PTCs. The ones on the right side of the line, the RAS, the PPAR gamma, the other non-V600E BRAFs, like I said earlier, these are the follicular neoplasm. These are not automatically cancers. These are, I have to make sure that there's no invasion and make sure that there's not cancer. The other random ones, like NTRK, so NTRK fusion is now becoming popular, is now becoming known and understood in thyroid cancer. These kind of straddle the line. They're very close on the low end of the BRAF, the low end of the RAF-like spectrum, but slightly more shifted that way. Right? We now realize that these are probably all cancers, and they're all generally probably PTC-like. So that's NTRK. And then the high-risk ones, like TERT promoter TP53, generally, especially if they co-occur with a driver, like BRAF plus TERT or RAS plus TERT, these are bad. And these are generally the combinations that you see in those high-grade ones. The high-grade poorly diff, high-grade diff, and anaplastic usually have a driver and then a secondary high-risk hit. Generally, those are TERT and TP53. We already talked about the oncocytic neoplasms sorting differently. Okay, I did want to mention a couple things about grossing, if you have 2 minutes, because we sort of want you to always correlate what you're doing with nodules that were seen on ultrasound and nodules that were FNA, because we need to tell them if the nodule that they what the diagnosis of the nodule that they were concerned about is, right? So if there's a nodule of clinical concern, we want to make sure we got it. We always want to have weights. Goiter is not a pathologic diagnosis, right? Goiter is enlargement for anything, hyperplasia, neoplasia, inflammation, whatever. So we don't ever make a diagnosis of goiter, but often these come in as quote unquote goiter. So just take the word goiter with a grain of salt, because if it's on our table, it's a goiter, like, right? Like it's not coming out because it's not abnormal. All right, we always fix these overnight, as we know, because we want preservation of the nuclear features. We want preservation of the peripheral margins of the thyroid, and we want preservation of the tumor capsule, which is inside the thyroid gland, right? The thyroid gland itself does not have a capsule, it just has a tissue plane. But any of you who've cut a thyroid fresh, and hopefully you won't and never will, it's messy and it slips and slides all over the place. And so you get all these artifactual slippages we try to avoid by fixing it in formalin overnight and having nice, clean sections. Because we could overdiagnose cancer just based on architectural slippage, and we don't want to do that. We know about inking. We specifically ink the isthmus differentially to know that that's where we are. If you have a cut isthmic margin, we just want to ink the cut margin, because that is in continuity with the other side of the gland, right? That is not in continuity with the soft tissue of the neck of the patient. So depending on whether it's a total or a lobe, we kind of consider the isthmus a little bit differently. If there is no appreciable isthmus and your things are like this, fine, don't do an orange, just do blue and black. I don't care. Generally sectioning them, as you all know, if there's a really narrow isthmus, just whatever, you can just do the whole thing crosswise. If it's a really long isthmus, that's when you can do the left to right. Okay. And what else? Oh, there's been a lot of questions on the modified transverse vertical approach, so I just wanted to clarify. What is this? Regardless of how you get there, what does it mean? It means if you have a follicular neoplasm that's of a good size, we usually say 2 centimeters or more, because if it's tiny, you're not going to be able to accomplish this. The point is to perpendicularly section the poles of the nodule so that we can identify the presence of capsular or vascular invasion in those poles, right? Not the poles of the gland, right? The poles of the nodule. I don't care if you need to bisect the thyroid longitudinally and see your 2 halves in order to see where the nodule begins and ends. I don't care if you can estimate where the nodule begins and ends based on the external examination. If that's the case, you don't need to do the longitudinal thing. The only reason to do this would just be to see what you're doing, right? Otherwise, if you can get your polar sections perpendicularly, that is the most important outcome as opposed to how you got there. But there's been some papers, documenting this approach because you might not know where these poles are based on the outer contours of the gland. That's the only reason to do this. Does that make sense? That's it. There's no other reason except for you to make sure that you can get these perpendicularly. This, of course, does not apply to PTC. This does not apply to medullary. This applies to follicular neoplasms in which you need to determine invasion. Yes? Yes. Okay. Things like this, right? Nice circumscribed borders. We want all of the poles perpendicular. Just photography. It's nice to have the outside. It's nice to have the cut sections. If you do photograph like all of your thyroid slices, which some of you do, that's fine. But maybe just isolate a couple and zoom in on them so that we get nice, high power, high quality close-ups of the tumor. So when it's all far zoomed out, it becomes really grainy and pixelated and kind of hard to see the details. Okay, so just always focus. I have an entire lecture on gross photography. For those of you who want me to give it, let me know, Chiefs. A number of years ago, we did it like on an afternoon with like snacks and drinks and stuff. So to encourage people to come, because it's kind of a fun one. It's not like a boring one like this. I'm just kidding. So thyroid is never boring. Okay, so grossing, multiple nodules, all the same representatives. Fun. Thyroid, obviously cancer, right? You can look at this and say, that's infiltrative, that's cancer. Sample generously. Sample the satellite nodules generously, right? So we also don't miss the fact that sometimes your nodule takes up the entire thing. Don't miss that there's a little bit of normal thyroid at the periphery, right? And don't call this a multinodular thyroid. This is a single nodule with a compressed rim of periphery, in which case you want to sample appropriately. When we talk about taking sections of the periphery, what do we mean? When we want to evaluate for capsular invasion, you want to be able to see the normal, the capsule, and the lesion, at least in these kind of semi-moon shapes, right? So if you want to put a few of these in one cassette, that's fine. I would never advocate submitting the entire periphery up front unless you talk to me first, because sometimes it's overkill. So generally, abundant sampling, and if we need to go back and put the rest of the perimeter in, we will. That's it. If you have small gland, 10 per lobe, 20 for total, which I think is in the grossing manual, you can just submit the whole thing, that's fine. These are pretty small, and we can look at them easily. If you ever have an opportunity to do a frozen on the thyroid, I'm sorry. Mostly we don't do them. Occasionally they will send because there's something unusual, but I advocate that you, on the cut section, you do a smear, and that's different than a touch prep for lymphoma. A touch prep for lymphoma, right? Lymphocytes are discohesive and they will just drop out onto the slide. Epithelial tumors, mesenchymal tumors, they have cohesions to their partners or are embedded in stroma. So they won't drop off. So what you need to do, you need to scrape them. You need to scrape the surface of the tumor with a scalpel blade, plop that stuff onto a slide, and then smear it with a second slide as if you were in cytology. That's the only way that you're gonna get any of those cells out. And the reason you do that is to preserve any possible nuclear features of papillary, because freezing artifact will kill the nuclear features of P2C. So if you are ever doing smears of any tumor for anybody, I would advocate that you do it in this manner rather than just a touch prep, because this will yield more cells. If you need me to show you how to do it, I can. That's it for now. Sorry I went over. Thank you for staying. It'll all be recorded. Questions? Okay. Next time we do unknowns, next Monday.